I was asked to talk on our president's behalf, Dr. Suleiman Heilen, and because he couldn't attend today. And the topic that was chosen is to talk about the aging female and the effect on her fertility. So the topic is the benefit of establishing an early diagnosis of infertility. Now, as we go through, I think you will start seeing why it's so important to keep in mind that the female is an aging patient, and with time, there is a line where natural fertility is not going to happen. Now, just a few things about our society before I start. SASREG is now older than 25 years already and was originally started by a small team of embryologists and Professor Creer in Cape Town. And it's currently the representative body of all reproductive specialists, embryologists, clinical sisters with programs, as well as psychologists that's involved in fertility treatment. As a society, we are also advising the Minister of Health on issues regarding reproductive health and gametes and storage of gametes. We are responsible for putting guidelines together in order to guide patients as well as care providers on what is ethical, what is right, what is scientific, and what is evidence-based. And some of those terms we will go through today. So our aim, our commitment is towards you as a patient. We are there in order to try and make your outcome in a safe, effective way in the shortest possible time. Now, that may not be so important for someone younger than 30, but someone older than 35, it starts becoming more important that the treatment you receive is evidence-based and is in your best interest and is, above everything else, safe. We are representing all the registered clinics in the country, and including the 3 big academic units and then 12 private units. We are part of a national and international database, as well as a South African database, where all the cycles done in every registered unit is reported on a national database, SARA, and then also on an African database, ANARA. And by doing that, we are in line with international standards of care regarding reporting of success. So as a patient, you can go onto the website and you can look at South African data on reproductive assisted reproduction. You can see what is a general success rate, and you can compare your outcome with that of national and international standards. It's just to make sure that every registered clinic is keeping to the strict principles of good care. Now, if I can start off with what is a reproductive specialist, because there's a lot of uncertainty about what is the difference between a reproductive specialist and a gynaecologist. While a reproductive specialist is registered as a Health Professions Council as a subspecialist in reproductive medicine, meaning we are gynecologists who went further in studying and did a fellowship, usually 2 years full-time or 4 years part-time, and to become a registered subspecialist. So our dedication is towards that field, and by definition you have to perform more than 50% of your day's work in the field of reproductive medicine. So you can't deliver babies and do gynecology and do 1 IVF a month and call yourself a reproductive specialist, because then you're not spending 50% of your daytime work as a reproductive caregiver. So that's it, but it's much more than that. A reproductive specialist is just part of a team. And the rest of the team is as important, and sometimes I think even more important. And I want to start off with the sisters. Without the sisters, we will not have patients. Without the sisters, we won't be communicating with our patients. And without the sisters, there will no one that the patient can contact with small questions, because the doctors are too busy. So after the sisters, we are so dependent on our embryologists. Now, embryologists they are scientists. They study for many years in order to become specialized in lab techniques and in human reproduction. And every dedicated registered unit must have a registered embryologist on their team. So anyone can't just be in the lab and start making human beings by putting sperm and eggs together. So very strict guidelines. And if I have to say, if you want to look at the success of a clinic, go and look at the laboratory. The laboratory reflects on the success of a clinic. And I think it's so important that you know that if you have a good lab, you're at a good clinic. Now, if we can start off just with a definition of what is infertility. Well, definition of infertility internationally states that the inability to conceive after 12 months of regular intercourse in women younger than 35, and in women older than 35, the definition of infertility states that you've been trying for 6 months and you're not pregnant. Now, I think it's extremely important to know that these time limits are based on international data across different population groups. But you can see there that suddenly, just by being 35, we give you only 6 months to try. If you're not pregnant after 6 months and you're 35 or older, there is potentially a problem. It is also classified as primary infertility if you've never been pregnant, including miscarriages and ectopic pregnancies, and secondary infertility if you've been pregnant, inclusive of ectopics or miscarriages. At least you've established a pregnancy, but it didn't necessarily lead to a live birth. So that's secondary infertility. If I have to say, and I think some of my colleagues will agree, that sometimes secondary infertility is more difficult to treat than primary infertility, because the simple question is, it happened, why is it happening not again? And in these patients, it's often lifestyle or age. We had a baby when I was 27, but now I'm 37, and 10 years later, I still can't fall pregnant. And something happened after your first delivery, or disease, or what else, and now you're battling. And to get you pregnant now at 37 is not double as difficult. It's probably 10 times as difficult to get you pregnant as what you've been at 27. What is normal fertility before we move over to infertility? Well, fecundity is the term we use to state what is your chance per month to conceive. Now, fecundity for women younger than 35 years is 22% per month. So it means that if you want to have a baby and you take out your intrauterine contraceptive device, or you start with sexual activity without contraception, or you go off the pill, with a pill it may take up to 3 months, but let's say you start with a pill, what's your chance the first month to fall pregnant if you're younger than 35? That is 1 in 5. So if 5 friends decide, let's stop the pill, 1 will be pregnant after the first month, and 4 will not be. But if we then take, how long will it take actually for you to fall pregnant? We can see that 3 months after exposure to sperm, 57% of the friends will be pregnant. It will take 6 months for 72% of the 10 friends to fall pregnant, and it will take up to 12 months before 85% of them will indeed be pregnant. So you can see the duration is double, but it only increases a little bit. So if you're not pregnant in the first 3 to 6 months, you can see that even in women younger than 35, something tells you that you're in the wrong way special. And 2 years later, 93% of patients will be pregnant. And seldom these 7 to 10% will fall pregnant in the next year or 2 without assistance. So I think this is very important. Now, put it more graphically, 0.3 gives you a 30% chance of being pregnant. So in the first month going off the pill or trying to conceive, in that first month, you have a 30% chance. But if you don't make it, then you're one of this group where it will take longer to conceive. So in month 2 to month 7, it comes down from 30% to about 20%, going down to about 10% per month. So your first month has 30, then 20, then 10. And then you can see at month 12, it's about 5% chance that now you will eventually fall pregnant. And that is why the majority of pregnancies is in the first 6 months. Thereafter, less women will conceive because you are starting to show yourself to be special. There's something wrong, either with you or your husband. But if we say you, we mean the couple. Now, this is a very reassuring slide. I think if we look at Dr. Danie's talk this morning about IVF, this is a little bit more reassuring. It makes a little bit more sense. And I want to say why. If you look at 100 women being fertilized, so fertilization of an egg cell does occur. Of that, 30 fertilized, which is now an embryo. So there's an embryo inside of you. 30%, well, let's start with, there's preclinical loss, meaning you didn't even know you were pregnant. And clinical pregnancies is you know you're pregnant. So 30% of embryos will actually not even implant, a third in nature. Someone asked a question, why would an embryo not implant? Well, the short answer is in nature, 30% do not implant. So we can expect that in IVF, where we're imitating nature, the same scenario will be present. So 30% of embryos do not implant. Then 30% will implant, but before you know, you're actually skipping your period, they will actually miscarry. So up to a year, you don't even know you're pregnant. So some did implant, some didn't implant, and you don't know it. So 60% of embryos either do not implant or get rid on their own much earlier than what we would expect. So now we are left with 40% of embryos that can become a baby. Of that, 40%, 12 to 15, will miscarry early on, and that leaves us with a live birth rate of 25%. So what I'm saying is, let's make it a very negative scenario. You have unprotected intercourse and you don't want to be pregnant. Without going to Mary Stopes, you have a 25% chance of getting a baby from that unprotected intercourse where you've actually been fertilized. So human reproduction is extremely ineffective. Extremely ineffective. And suddenly, when you're not one of that first 80% of patients that conceive within the first 9 months, you start to feel everything is wrong with me. But you must remember, you're a human, and human reproduction per se is not very effective. So may this help you a little bit to understand, if you've had previous inseminations or IVF, why in the world didn't it work? It looks so good, and you're so cross with the team because the doctor, the sister, the embryologist, everyone said it looks so good, it looks so good, it looks so good. And yet it failed. This is why we cannot make babies. We can only assist trying to establish a pregnancy, but we do not make the babies. Now, the next thing that I just want to say is, what are the causes of infertility, just in a nutshell? Not going to go into too deep because that's not the reason that I'm talking and the topic. But if we look at all causes, I think this is important that we just look at male and female causes. And then we will see there that in 35% of couples, it's a male problem. Now, all fertility clinics and specialists will tell you they battle to get a male to go for testing. It must be a female problem. Because men are men, they make babies. Women are the ones who can't give him a baby. But in a third of couples, it's a sole male problem. There's not another female problem as well. It's only a male problem. In 35% of couples, there's a female problem of tubal and pelvic pathology. And then we see that in a 15% of the whole population, women are not ovulating. 10% is unexplained. And when I was an undergraduate student, that was 30%. So we're down to 10. Because now we have better microscopes, we have better enzymes, we have better technology, we have better embryologists, we have better surgeons. So we know 20% more patients will now know why they're not falling pregnant than 15, 20 years ago. And in 5%, there's unusual problems. Now, under unusual problems, of course, someone who's single or in a same-sex couple can't conceive, and they will probably now start to fall in that group. But then we go specifically to the female. And so 35% of couples are male. What about this, the 65% of females? If we divide them, we will see that in 40% it's still tubal and pelvic pathology, and this is especially true for South Africa. If there was something like a second world country, we're that. We're first world or developed, and a huge part of undeveloped or developing. And that is why we have a lot of tubal and pelvic disease, which are actually good prognosis patients. If the government and medical aids would just pay for IVF, these are the wonderful patients that will conceive. They did conceive or had ectopics, or the tubes are closed, but they're young and they're reproductive, but the tubes are closed. If we can just get that sperm cell or the egg cell, bypass through the cervix and put it in, they are good prognosis patients. So if you hear that your tubes are closed and your husband is normal, there's no problem there, you're actually a very good prognosis patient if you're younger than 35. Ovulatory dysfunction now becomes big. It's 40% of women are not ovulating, and that includes the polycystic ovarian syndrome, obese patients, anorexic patients. Those are the anovulatory ones. 10% are unexplained again, and then 10% with unknown. So if we then look at female factors today, I'm just going to address age. But there are other factors. Lifestyle. Our modern Western lifestyle is detrimental to human reproduction. It is not a good environment for the human body to reproduce. So unfortunately, a sedentary lifestyle, high intake of refined foods that doesn't have the necessary vitamins, anything, we had a talk about that this morning, contaminated water, poverty, on the other side, all leads to lifestyle factors. But the biggest one at the moment, epidemic in South Africa, is that 50% of adults are obese. So lifestyle leads to lesser pregnancy outcomes naturally, but also in IVF. If you're overweight, your IVF success rate goes down, both for male and female. I'll talk about that more when we come to the male. In females, I can just say that fat tissue produces estrogen. So there's an excess of estrogen which suppresses your brain because you're actually now on a contraceptive pill. Your brain thinks you're on the pill because you get all this estrogen from the fat tissue. So anovulation is a high problem. Drugs, of course, whether it's drugs prescribed by doctors or chemotherapy. In the next line, drugs is unfortunately having a negative effect, and cannabis, that is going to be the solution to everything except our economy, or even maybe the economy. It's not going to help our fertility. Radiation and chemotherapy, unfortunately, leukemia and lymphoma in young adults is common, as well as other tumors that patients go through, and then they do not receive the necessary counseling to go and pull some eggs and do egg freezing or sperm freezing before they start their chemotherapy. And I think you'll say, I don't know if you give a talk on that, but that is what we call these days oncofertility. And it's so important that we know that you have one chance. Freeze your eggs or sperm before you go for chemotherapy. If you have breast cancer diagnosis in the reproductive years, 10% of breast cancer patients are in the reproductive years. Freeze those eggs, otherwise chemotherapy will be toxic to your gametes. Genetic, of course, we do have things like premature ovarian insufficiency. The old name was premature menopause, where menopause is at a much younger age than the average 51 years. So that may be genetic. Iatrogenic is us, doctors. We go and operate you for endometriosis, and we think we must take out your ovary, which is the worst thing you can do. So for endometriosis surgery, as part of reproductive medicine, we operate patients with endometriosis and fertility problems, because you have to take the whole picture into account when you operate this patient. You're trying to enhance her fertility, and to take out the ovary is halving her egg pool just there and then immediately. So iatrogenic means done by doctors or medical care, or what form of care you can think of. And then disease, of course. Even rheumatoid arthritis may have effect. But, of course, viral diseases, mumps and things like that, more in the male, but in females it may have an effect as well. So disease per se can cause patients to struggle with infertility. If we look at the female physiology, this was actually fascinating for me when I went to specialize as a general gynecologist, firstly, that the female reproductive system does have the clock that everyone talks about. But it's fine to say a clock, but how active is this clock? Well, that clock is very active. It is all about the oocyte quality and not about the quantity always. But of course, it doesn't help to have one good egg. You need many eggs. So it's always quality versus quantity. Now, when you've been inside of your mom as a female, when she was halfway through her pregnancy, you had 6 to 7 million eggs. By the time you've been born, you had 1 to 2 million eggs left. By the time you reach puberty, you had 300 to 400,000 eggs left. And then every month, well, every day, you lose 30 to 65 eggs. So coming to this show has cost you some eggs today. You've lost some here in the seats. So you lose 30 to 65 eggs daily. So in a month, you lose 900 eggs on average. So on average, a healthy female will have 400 ovulations, and then you're menopausal or sterile. Oh, sorry, not menopausal, sterile. So when you start your reproductive years at puberty, you only have 300 to 400 eggs left, 1,000 eggs left. And then there's a rate of follicular loss. So every day you start losing eggs, although you only ovulate from 1 egg a month, you lose hundreds of eggs every month. But only one becomes the egg that will actually ovulate. The rest you just lose. And all we do with IVF is to go and harvest those eggs that you would have lost anyway. So if one of you have a question, are we not stealing your future eggs? No, we're not. We're using what you're losing. Remember that. We're using what you're losing. So we just go and harvest more eggs. They grow as a cohort. Almost a sisterhood of eggs will grow this month of March. And April, there will be a new sisterhood of eggs maturing. And that takes about 90 days, the cycles of eggs. And one will come free in March, one will come free in April, but the rest all undergo natural programmed cell death. If it loses its ability to die, we call it a cancer, because then they start growing like a cancerous cell. At age 40, you have about 250,000 left, but unfortunately now the quality is bad. And at menopause, you still have about 1,000 eggs left. And that is why if your twin sister who has kids comes at 50, and she asks if she must still use contraception, we say yes, until at about 52. If you come at 50, you say you still want a baby, we say it can't happen. It's just what you want. If you don't want a baby, it can still happen. If you want a baby, it's not going to happen, because there's just not enough eggs. But we can't say you're sterile. Now, if you just look at this slide, as you age, this is the number of follicles that you have. The follicle is that little thing in which the egg grow. And this is the abnormal oocytes. So at one stage, it's going to cross. So your peak fertility is between 20 and 30. That is where we as humans were made to have kids, between 20 and 30. But now you become CEO, you travel the world, you struggle to study, Before you know it, you're past that. So anything we say will be less effective after 30. That is just the way it is. So your follicle count comes down all the time. And then after 30, the quality of the egg is also becoming abnormal. So you can see at 50, 100% of oocytes are abnormal. And this is the reason why older women are more inclined to have Down's babies, or abnormal babies in all. Down's is just one of the examples. Because a 39-year-old female, her eggs are 39 years old. Her husband's sperm is, yes, it's a man's life, 89 days. So one of our prominent leaders managed to make young girls pregnant, but not these old wives. So you must always remember that. Men can make babies up to 70, but females not, because you don't have eggs left. So that's very, very important. So when it crosses over there, then you may have an egg, but it's not going to be normal. And that line is actually moving back when other things like endometriosis, mumps, disease, poor nutrition and things has had an effect on this line. So if we go and take out an ovary with an operation, that blue line comes down the year. Because it's 2 divided, take 1 out, you've got 1 left. So that's so important. The fact that you've got 2 doesn't mean you can lose 1. I always tell that to my male colleagues when they take out ovaries. I say if it was a testicle, they would probably have kept it. So this is the effect of aging on pregnancy outcome. So if you look at, it is not the uterus that gets old, it's the egg. Because if we substitute the egg with a young egg, the pregnancy rates are the same. So it is not the mom that's getting old, it's her ovaries that's getting old. So if we can just get a younger egg on board. So if we do IVF with own eggs at 42, this is live birth rate. Our live birth rate there is probably nothing more than 4 to 8%. But if we now substitute just the egg, use her husband's sperm, and put back a donor egg with put the embryo back, you can see we can have up to 50 to 60% live birth rate in that 50-year-old uterus if we just substitute the egg. So that is why donor oocytes is often such good news. I'm from the Eastern Cape. A lot of our patients come from the Transkei. In the old apartheid days, they didn't have internet, they didn't have jobs, they didn't even know about fertility clinics. So now they're 46. Now they do have jobs, they do know about IVF clinics. Now they come at 46. And if we offer them donor oocytes, that 46-year-old woman who's never had children suddenly becomes a mom. But we must just get her over that idea that you can still be a mother. And that is what we look at. And every clinic will tell you that that's their experience. An old uterus can carry a young egg. Now, to put that in more perspective, is you want to know what's your chance of falling pregnant. Now, all of you who's been at fertility clinics will know the AMH, that expensive test, anti-Mullerian hormone. It tests the amount of eggs that you have left. And at 30, if we have 10 metaphase 2 eggs, Dr. Danie this morning explained what's a metaphase 2. It's a mature egg. If you can give us 10 mature eggs, you have a 60% chance of taking a baby home. That's children, not pregnancies. So if you have 10 mature eggs, you have a 60% chance of taking a baby home. But with 10 mature eggs, you also have a 20% chance that there will be enough embryos that in a year or two you come back, we put it back, and then you have a 20% chance of another live birth from one harvesting. So if you can give us 10 mature eggs, you have a 60% chance. But if you are 41 and you give us 10 mature eggs, you only have a 20% chance of a live birth. But the problem is 41-year-olds do not give us 10 mature eggs. You probably have to do 2 or 3 harvesting cycles. Harvesting 3 eggs, do another IVF, harvesting another 3 eggs, do another cycle, maybe harvest 2 or 3 eggs. The problem is old eggs don't freeze well and old embryos don't freeze well. So we're in a dilemma when we sit with this patient population. In general, you can look at real life, a 4% live birth if you're 42 or older. 4%, that's it. The best clinics in the world, 4%. So how is it possible that only the actresses at 46 can get babies? It's because they use donor eggs. And that's why they usually have twins. So if you look at an actress of 46, most likely she used donor eggs. Now that is just to put it a little bit in perspective. If we quickly look at male factors, I said age. After the age of 40, the male also becomes important. And we now know that abnormalities and psychological disorders like schizophrenia is more in offspring of men who's older. So unfortunately also, childhood cancers are more common in the children of older men. Although it's very low still in real terms, statistically it is definitely higher. So if you use sperm of a 70-year-old, you'll most likely get his 26-year-old wife pregnant, but there is that information that must be given that there's a higher incidence of childhood cancers and psychological abnormalities. Lifestyle, with obesity being number 1, excessive exercise we thought was a big thing, it doesn't seem such a big thing anymore, but drugs and smoking are killers. If one of the two in an IVF cycle, male or female, is smoking, your pregnancy, your outcome falls with 40%. So if you are doing IVF and one of you are smoking, and we said your success rate to have a baby is 50%, now it's 40% less 50%, so now you sit with a low success rate of about 20% to 25%. It's 40% off, 50% down. So that's massive. And then trauma, of course, with rugby and cricket and car accidents to the testicle. Surgery, where the male has undergone surgery for a testicular tumor or previous vasectomy and a failed reversal. Mumps is a big one. So if you have mumps and it has affected the testicle, then there's a high chance of infertility. Infections, unfortunately, STDs, radiotherapy and chemotherapy, and then chronic diseases as well. I'm going to skip that slide. I can just quickly say what is important about sperm is sperm can survive in the female reproductive tract easily for 3 to 5 days. So you're going to ovulate on Tuesday, day 14, but your husband leaves on Sunday. If you have intercourse on Sunday, there's a good chance that you will still fall pregnant. But unfortunately, eggs can only be successfully fertilized for about 12 to 24 hours. And within 24 hours, that success rate, you did ovulate on the Tuesday and your husband returned Wednesday morning, you have intercourse. It's probably just too late. So husbands can fertilize or males can fertilize for 3 to 5 days prior to ovulation, but women are stuck 12 to 24 hours. Management, I think it's important, just quickly in a second or two. We have moved away from, especially in women 35 or older, to look at every single detail and try and establish that. And yes, it's important. Get the weight down, get the weight up, stop alcohol, stop smoking, lifestyle. All those things are important. But we're not going to give you a year to try and get fitter or lose 1 kilo. We're going to move ahead and do IVF as soon as possible. We can always freeze the embryos and then you go and lose your weight. But after 35, we hurry up and get you pregnant. The largest majority of patients that do not conceive within 3 years will very unlikely conceive thereafter. So if you're struggling with 5 years and you're still wondering if you need help, the chance that you will conceive is very, very little. Now, clinicians caring for infertile couples should keep these 4 basic goals in mind. And I think when you're at the clinic, or whatever form of treatment you consider, it's very important. We have to identify the reason. We have to provide accurate information about that condition and how it affects your fertility. We have to provide emotional support, and that's why all registered clinics have psychologists on board their team to help. And we have to guide couples who's had several failures. And at one stage, as a doctor, your responsibility towards a couple is to say enough is now enough. Either stop, but don't do a 12th cycle. Don't jump from clinic to clinic. You've been in good clinics. If they couldn't get you pregnant, we're not going to get you pregnant at 47 with your own eggs. So stop. That's our responsibility, ethics of medicine. Alternatives will be other forms of IVF if you've done inseminations, but sometimes we have to go for donor or adoption, or just say, move on with your life, you've tried. Just quickly, again, international guidelines. If you are younger than 35, try for 1 year. Older than 35, 6 months. If you're 40, you don't try, you immediately consult. I'm getting married next month, I want a baby, I'm 40. You see the doctor the day after, and you try. But also women who's not menstruating should see their doctors immediately. They mustn't try for 12 months. Patients with known suspected medical conditions, patients who's had previous endometriosis surgery, patients who's lost an ovary, they need immediate help when they want to try and have a baby. Female have lots of investigations, male have lots of investigations. I only have a minute left, so I'm just quickly run through it. Regarding the treatment, these are the obstacles that we find to effective treatment. And we said that why is it important to have an early diagnosis of infertility? Well, it's important because the road ahead is long and expensive and emotional and lonely. First of all, there's fear of failure. Now you are going for the IVF, but what if it doesn't work? So I'd rather not try. Men are fearing the diagnosis that the problem is maybe with him. Finances, a massive problem. Economy is down. We're coming from a very poor area in South Africa, and finances makes it impossible. The medical aids are not paying, the government can't. Family is putting pressure on you. When are you starting with a family? You've started 6 years ago. When are you starting with a family? When? Now they know you're going to go through an IVF cycle or insemination. They want to know, is it working? How's it going? Friends wants to know. Faith. Is it right? Are we interfering with God's plan for my life? Is this what God wants for me? Maybe God wants me not to have children. I can tell you that is in my faith not true. We spoke about the loving fatherhood of God. In all religions, God is blessing people. But disease steals children, not God. So that's my personal opinion. So faith may impair alternatives like donor eggs. Some religions just don't allow it. So then you really hit this area where you can't go. And then facts. Google is good if you want to find the spur, but it's not always good to find a road to fertility. And that's very important to know the difference between a pizza and an egg. What is evidence-based medicine? I'm not going to say much about it, but that is what Western medicine is all about. And just to use an example, the Cochrane database looks at everything that was published. I always use Annie van Koekenhaap, her opinion on Facebook, what is good medicine. It's not good medicine. It's never been tried or trusted in randomized trials where half of patients get treatment, half gets placebo. I just want to say what placebo means. If I give you something, a vitamin, and I give you a treatment, there's a 40% chance that the vitamin will do exactly the same as my treatment. So that's the placebo effect. So any study has to prove that it's doing better than 40%. Otherwise, we call it the placebo effect. So yes, you may get people pregnant by giving a lot of advice, but it's not going to, in a randomized trial, be shown to be effective. So everything we do is tested. Every single study in the world that's in a well-conducted manner undergoes scrutiny, and if it doesn't survive the Cochrane, it's not going to make an impact. Just for those who do have a child, this is just an example, acute otitis media in children. If you go to your GP, he has to prescribe antibiotics to 20 children with otitis media before it will make a difference. So 19 will get antibiotics unnecessary. Who should treat couples, individuals presenting with infertility? I think you have to decide on that. We are different in every way. We are different in our attempt to fall pregnant. But if you're older than 35 and you're not pregnant, I think you have to make a plan to see someone who can help you to get there. This is the take-home messages. accept the possibility that you may be subfertile or infertile if it didn't happen in the time frames I gave. Act upon what you suspect. Don't wait longer. Get professional help early on. Establish a treatment plan together with your caregivers and individualize your treatment. You cannot get pregnant on the internet by using the same thing over and over for all patients. If you do not get individualized treatment, you're not going to be successful. Be clear about your expectations and possible outcomes. If you're 46, you're not going to fall pregnant with your own eggs in no clinic in South Africa. It will not happen. Your chance is probably better at home. Do your homework, and with that I mean read, but be careful what you read. If you make a decision to go with a clinic, stick to that clinic. They know about you. They know what you've done in previous cycles, unless you get bad treatment. But trust your team. They do have your best interest at heart. And lastly, before I conclude, make sure there are people who will support you. Make sure that your faith is strong going into this. Make sure that you have put your trust in your religion, in God, as well as in your partner, as well as in your team of caregivers. And make sure that as a couple, you have the companionship and never lose that. And then from a very friendly city of Port Elizabeth, where the sea is much closer than Gauteng, I say thank you for the invitation.